Presenting a case of male 25-year-old present to me with right-sided recurrent facial pain with headache for last since 6 months. Patient having right-sided nasal obstruction since last 6 months. On history, there is sharp shooting, deep-seated pain around the eye, cheek, and upper jaw. Episodic pain last minute to hours, often triggered by cold air, nasal congestion, or exertion. On anterior rhinoscopy, there is right-sided septal spur impinging on the lateral nasal wall. Anterior caudal dislocation of the septum on the right side. On endoscopic view, there is contact point between the septal spur and middle turbinate on the right side, and left caudal septal dislocation seen intraoperatively. So on clinical endoscopic and CT scan findings suggestive of Sluder'S neuralgia secondary to right-sided septal spur with anterior caudal dislocation. Plan is endoscopic septoplasty. There is removal of right-sided septal spur by endoscopic view by septal flap elevation, you can see in this picture, and correction of anterior caudal dislocation with preserving the septal support. And you can see intraoperatively there is right-sided septal spur impinging on the lateral nasal wall, and after elevating this flap you can see this is sharp bony septal is there. That septum spur is leading to impinge on the lateral nasal wall or inferior part of the middle turbinate. That a cause of the spinopalatine branches irritation that lead to pain on the right, headache, and right nasal area pain. That is suggestive of Sluder'S neuralgia. After elevating this septal flap endoscopically, you have to do this bony correction by elevating or cutting this bony spur by the chisel and hammer. So I am using chisel and hammer so that I can break this hard bone of spur, and now I am doing with chisel and hammer so that it hard bone can be break easily by this. After breaking this, I have to elevate this on the other side flap by this maneuver by elevating my chisel only. So after chisel thing, you have to cut this superiorly, inferiorly, and all around so that I can remove this septal spur easily without any damaging the superior and inferior part of the bony septum. After releasing by cutting by the chisel from superior and inferiorly, you have to remove this by the straight forceps so that this bony chunk can be removed or this spur can be easily handled by this maneuver so that there will be no damage in the cubriform area. So after doing this, you have to just elevate the opposite flap and you have to remove this bony spur part. Now it is free from all around. Then I have to catch it with the forceps and remove it by the forceps rotating motion. First you have to just check it, and this is comes out easily. After you have to check if there is any part of this septal spur is remaining behind, so that you can removing this you can see posteriorly. If any part of the bony septum or this spur is remaining, you can just do same maneuver by chisel hammer and you have to remove the last part. You can see behind is also a small spur is there. I have to remove that also. Endoscopic septoplasty is effective when neuralgia is secondary to an anatomical contact point. Success rate is about 70 to 80% if neuralgia is at the contact point mediated, which leading to irritating the branches of the spinopalatine ganglion. Even though this Sluder'S neuralgia is controversial entity, but if patient getting benefit by doing this type of maneuver, then you have to do it, because a lot of patient getting relief by nasal obstruction as well as this contact nasal severe shooting pain. So you have to correct this, and this correction lead to about 70 to 80% correction of nasal or pain symptoms. Then I have to do it, and that is very effective maneuver. And see, their last part also corrected by endoscopic mean. After that you have to reposition this flap so that you can check there is any elevation of remaining part of the bone there. Now last chip is remaining, I have to remove by just catch by the forceps only. After repositioning this flap, I will have to suture by Vicryl 30 through and through suture so that I can suture this anterior dislocation part also by the same suture. So I will pass one suture from this left nasal cavity, taking this flap inside the needle, then pass it on the opposite side, and I will take the needle from opposite and pass on the anterior dislocation part by the same suture, then it suture on the left anterior part so that this will be completely fixed by this suture. So both posterior flap on the left side and anterior flap on the right side can be handled by the same suture, and it will not fall back or slip from the location from this suture. This flap is elevated. Post-operative care, you have to keep nasal pack for about 24 to 48 hours. After removing the nasal pack, you have to give saline irrigation, antibiotic and analgesia for 7 to 10 days. Avoid nasal blowing or any trauma or nose picking by the finger so that there will be no bleeding post-operatively. After fixing this suture, you are secure if your nasal pack is removed within 24 hours. That flap will be fixed by this suture only. So I always take Vicryl 30 suture on the septoplasty so that I'm sure there will be flap fixation and there is no post-operative bleeding by fixing this flap by the Vicryl 30.